you submit your papers, because I think all the scientific committee has gone through uh, the exhaustive work of going through everything, selecting the best papers. Are you one of the presenters? No, okay. Sure. All right, so I think because Dr. Sanskrita Sinha is not here, we will go to the next presentation. This is going to be by Dr. Zain Khatib, CAMP protocol with Zoom simulator, a new proprietary software for hyperopic presbyopic LASIK planning. Yeah. So the free paper code is 425 and the membership number is K17738.
Good morning, Vardhaman sir, Bhasin sir, all the respected audience. I'm going to present my paper on something called Zoom Simulator. Is a proprietary software which I've been working on for presbyopic LASIK since the last 2 years. This is for the Alcon wavelight model, and it is based on the mathematical foundation by Professor Gatinel in 2016, which came up with the Reed model, that is refraction enhanced by asphericity distribution. And as per the Reed model on the wavelight platform, although not available in India right now, they make the non-dominant eye Q value extremely negative by zero 0.6. So if the starting value is minus zero 0.2, it is made to minus zero 0.8, and a refraction of 2.5 is added. So if the number was plus 1.5, the number becomes plus 4. And this is how depth of focus is induced in the non-dominant eye. The logic is simple. If you've got a hyperopic cornea, rays are focused behind the retina. When you do a hyperopic treatment, you are making the cornea hyperprolate by ablating at the periphery, so the rays focus on the cornea. But if you selectively ablate more at the periphery, making the Q value more negative, you're going to get a flatter periphery compared to the center. So the peripheral rays will focus behind, central rays will focus on the retina, and then you add power on refraction, which will then increase the depth of focus. So this was the Reed software by Professor Gatinel, but what I had experienced was that if we change the value by more than minus 0.36, the quality of vision is affected. So I had come up with a controlled asphericity modulation for presbyopia, where we do a maximum Q value change of only 0.36, but both eyes can be treated, not only the non-dominant eye, and we can combine it with monovision and the patient's natural accommodation. And how to know how much of each of these is used, that is where the Zoom simulator comes in. So I'll just explain it with the help of an example. This is a patient's refraction, near addition is 1.5. We define a term called as binocular inherent accommodation. How much is the patient's natural accommodation? So it is 2.5 minus the reading add. So in this case, 1 diopter. And we define the eye for monovision and the maximum tolerable monovision to the patient, in this case 0.75. And we then go into the Zoom simulator, which is freely available online. So it shows you these ray diagrams, and then you can just feed in all your data over here, feed in the monovision, feed in the binocular inherent accommodation. It will show you how much depth of focus is coming from the treatment itself. Then we can add Q value change up to a maximum of 0.36, and the refraction changes. And now these bars on the diagrams will show you how much is the depth of focus you are inducing. And you can keep doing this because you've got visualization, and you can do a binocular overlap as well, where you see the how much is the 1 to 1.5 diopter binocular overlap, so that you don't lose stereopsis. And then it will give you the final treatment plan in terms of Q value and refraction required. So we wanted to study the safety, efficacy, predictability, and patient satisfaction at 6 months post-op using this software. We retrospectively analyzed our patients between 40 to 60 years, hyperopic presbyopes, and we got 52 eyes of 26 patients after analyzing. We did a standard monovision tolerance protocol. It was a femto LASIK done, custom Q on Wavelight EX500 with a Zemer femtoflap 6 millimeter optic zone, post-op assessment at 6 months. These were our results. So you can see the mean age was 48 years, and the refraction was about plus 2 with a cylinder of plus 1.75. Now if you look at this first bar diagram, this is the uncorrected distance visual acuity. If you look at the green bar, it tells you 88% were binocularly 6.6 or better, and 100% were binocularly 6.9 or better for distance. And the yellow bar is also interesting because this tells you only the near eyes. So it tells you that even the near eyes was 6-9 or better in 81% of eyes. So the near eyes also, because of the depth of focus, was not bad for distance. Similarly, if you look at the uncorrected near vision, the green bar, it tells you 100% eyes were J3 or better. And if you look at the blue bar is the distance eyes, it tells you 92% eyes were J5 or better. So again, the same concept that even for near vision, the distance eyes are not bad. So because we are inducing depth of focus by Q value modulation, we are getting good stereopsis, as well as the distance and near eyes are also good. Safety profile were met in terms of refractive surgery standardization. And we just did a subjective questionnaire, distance, near and unaided reading comfort. The mean out of a score of 1 to 10 was around 8.5. 77% patients said that they were 100% spectacle independent, and dysphotopsia score 88%, I said no dysphotopsia, and 12% said mild grade 1 dysphotopsia. So to conclude, the CAM protocol guided by Zoom simulator offers a safe, effective and highly customizable approach to treating hyperopic presbyopia on the Wavelight platform. Thank you.
Thank you, Dr. Zain. I think it was very interesting concept. So basically, what do you think were the drawbacks of the read protocol, and what does this new protocol have advantage over the read protocol?
So first of all, sir, the read protocol commercially is not available right now in India. No treatments have happened, but you can do it manually by overriding and doing what it does. The problem with read was it treats only the non-dominant eye, because it is doing such a high Q value modulation that it is actually affecting contrast. So because you are doing a 0.6, instead of inducing spherical aberration, you are actually creating a multifocal cornea. When you create a multifocal cornea, it always affects vision. So that is why when I had started doing it, patients were not happy. And that is why it is done only for the non-dominant eye. So we tried doing R&D to see what Q value is the patient tolerating, and we realized that if we are going up to a maximum of 0.3 or 0.36, then in that situation, the patient's contrast is not getting affected. Patients are happy, so much so that you can do it in both eyes also. That was the concept.
And so basically the monovision that you pushed them for was 0.75 maximum. Beyond that
No,
also you did for few
up to
people?
1.5 we
Okay,
can do.
so maximum tolerable.
Yeah, but we never found in our study, we did not find the need to go that high because of
Okay.
the Q value. So we were very specific that if patient had even little ghosting while seeing the images on monovision, we would not allow it. We would do it until patient says that they are absolutely comfortable pre-operatively.
All right. So yes, please. So Dr. Monica is joining me now in the judging panel. Welcome, Dr. Monica. Yes. So basically now, in terms of the age differentiation, because you started from 40 years, I think you went up to 60,
Yes.
I believe, in this. So so was there any specific bracket of the age where you have seen that this worked better versus the, let's say, younger versus older, 40, 50 to 50 to 60? Any observation between this?
Actually, because of a small sample, I couldn't do the diversification on age. But yes, the ideal age it works is between 45 to 50. The reason being, at that age, the tolerance is much better. And above 50 to 60 also it works. But only thing is you have to take the Q value to very high. So I take Q value to 0.36 in both eyes when we are going at that 55 plus. We have done patients at that age and they're happy. So the whole purpose of the simulator is that you can see it in front of you what you are inducing. So little less binocular overlap happens, and we need to do little more, push little more monovision. So those were actually the patients who were little less, that dysphotopsia was little more, but they were also happy. So there were only two patients who were unhappy in this group, and they were mainly because the distance was not corrected. So distance has to be absolutely perfect, otherwise it doesn't work.
And the last question is, how did you, for the patients who are in the old age group beyond 50, how did you rule them out not to have any kind of lenticular aberrations? Did you do eye
Yeah, that
tracing
was
on them? Yeah.
no, it was on
Okay.
slit lamp examination.
Straight lamp examination. Okay, sure. Okay, thank you so much.
Thank you.
Thanks. Right. So I think Dr. Jatin is not here, I believe. So I think we will go to the next presentation by Dr. Purendra Basin, sir. It is going to be by on phakic IL implantation with monovision for myopia in early presbyops. The membership number is B06497 and the free paper number is 629.
morning, everyone. I will be speaking on phakic ICL implantation with monovision for myopia in early presbyopes. I have no financial interest. With the background of rise in myopia trends in all over the world, and there is a strong desire to get freedom from glasses. And monovision is a proven presbyopia correcting strategy, but it is not utilized for phakic IL surgery, and the modern Centraflow V4C ICL design has nearly zero incidence of cataract in the 5 to 7 years study which has been done recently. So, with this introduction, and various options are available like laser vision, refractive lens exchange, and phakic IOL. We chose phakic IOL to correct presbyopic myopia because the corneal biomechanics are preserved, it is reversible, accommodation is maintained, it corrects very high myopia, and with excellent optical quality, minimal higher order abrasions, lower risk of retina as compared to refractive lens exchange, with the aim to retrospectively evaluate the visual outcomes, patient satisfaction, safety and predictability of phakic ICL implantation with monovision in early presbyopic subjects having moderate to high myopia. We took up this study. It's a retrospective observational study. Ethics committee approval obtained. Minimum follow-up of 6 months. 20 eyes of 10 patients included. Age Mean age was 46 years. 4 male and 6 female. All patients completed more than 6 months of follow-up, and we included presbyopic age group patients with a stable refraction, patients dissatisfied for spectacles or contact lens, open angles, ECD more than 2000, ACD more than 2.8. With we excluded patients with cataract, keratoconus, and or other corneal pathology, glaucoma, uveitis, severe dry eye, retinal pathology, and no systemic disease. And complete preoperative evaluation is done, and specific emphasis on AC depth, which should be more than or equal to 2.8 millimeter, excluding corneal thickness, and corneal horizontal wide to wide measurement, optical biometry, pentacam nuclear staging, eye trace aberrometry, dysfunctional lens index, macular OCT and specular microscopy, and pupil size, which is very important, has been considered. And we planned monovision, and the ocular dominance testing is done in all patients as per the criteria. Non-dominant eye was undercorrected by -1 to -2 diopter. ICL power and size were corrected, we checked by the nomogram by the company. And as you can see this example, the patient is having -10.25 diopters of myopia in both eyes. We undercorrected by 1.25 diopters in the left eye, and this is the surgery short clip. Preoperative full dilatation of the pupil, topical anesthesia, 3 millimeter incision, lens is loaded, it's a preloading, front loading system, and OVD is injected into the anterior chamber. The lens is pushed over the surface of the iris, and with the help of spatula, the haptics are tucked behind, and the axis is aligned to the desired axis of the ICL, and OVD is exchanged with the BSS at the end. So patients were followed at day 1, week 1, 1 month, 6 months, 1 year, and we assessed vision, IOP, vault height, lens clarity at all visits. This is the list of 20 eyes of 10 patients. We divided into 3 groups, and 40 to 45, 45 to 50, and more than 50. And the myopia range from -2.5 diopters to -19.5 diopters. 1 to 2 diopter undercorrection was planned. 6 months mean follow-up is 1 year, 2 months. No intraoperative complication, 100% achieved target. And uncorrected distance vision was 6.9 to 6.6 depending on the pre-op vision, and N6 to N8. 4 patients required spectacles for fine prints, and monovision tolerance was excellent in all patients. In one patient we had to do redialing because in the toric ICL patient. And the safety outcomes: no cataract formation till the last follow-up, no IOP rise or angle related events, no pigment dispersion. The limitation of this study is there is a small sample size, it's a retrospective design, and there is a short follow-up. To conclude, early presbyopes can be corrected by phakic IOL with monovision, And in carefully selected subjects, phakic IOL is not a compromise. It is viable and effective refractive surgery with larger studies needed to confirm the long-term outcomes. Thank you.
Okay. Thank you, sir. Sir, now when we look at the presbyopic correction with phakic lenses, monovision approach versus the new ICL which is come, which is the Viva. So have you done any comparison between this two
No, I have
approaches?
not done any comparison, but
Yeah.
the Viva, there is a limitation, and patient tolerance is also not very good in all myopia, the different, all range of myopia. They say that if the myopia is 4 to 5 diopters, that on, in that group it is very effective. So here there is no such limitation, and monovision is an established technique, and that's the reason why I chose this. And as you can see, we could correct from 2.5 diopters up to 19.5 diopters. So now we see that a lot of patients they come to us for the myopia correction after 35, 40 years of age.
Right.
So this is a new trend which I am seeing, and in our practice.
So were these patients LASIK rejects or these patients were primarily chosen for the phakic lenses?
That is a very good question, because these were all we chose primarily for this phakic IOL because of the quality of vision, and the IOL power calculation in post LASIK eye is difficult. We cannot do premium IOLs in all these patients if we do the laser vision correction, and dry eye issues. And in laser vision correction, there is chances of overcorrection in higher age group patients. So that is another issues related to the laser vision correction. So I do in limited age group patients, but around 40 years, I think this is better than laser vision correction.
So have you tried presbyopic lenses from AIOC?
They all,
Presbyopic IPCL.
yeah, that's what
Yeah,
the
yeah.
previous
But
question was.
yeah.
And I have not included IPCL or Indian lenses. I have used only ICL in this group of selected. But I have used in one or two patients, but I didn't find it to be very helpful. I'm not very happy and keen.
I have to never used. I also don't believe in that technology. But
Yeah. Yeah, and in one eye only, that has to be, that is, they say
how
that
about
you can.
stereopsis? What is the?
That is very good. In stereopsis also, patient has didn't had any good, didn't had any problems in routine work, day-to-day work, and all these eyes.
Yeah.
And it has been more than 4.5 years now with when I started in my last this thing case. So they all are doing good. And
Okay. Thank
thank
you,
you.
sir. Thank you so much.
Only thing is that a pre-operative the clear the lens rise should be checked, and the lens the natural crystalline lens should be checked thoroughly, and all these the pentacam and the eye trace, they help us in finding out whether there is a pathology is the corneal, or the refractive error is some amount of refractive error. If it is lenticular, then we will not select for it.
Right.
That is
Obviously,
very, very important.
that is
Sure.
there.
Thank you. Good. So I think we'll come to the next presentation by Dr. Kavita Lakshmi. This is going to be transepithelial PRK versus alcohol-assisted PRK, a contralateral eye comparison of 40 eyes. Yeah. Zen Katha, Chada. So we'll have, yeah, it's a new thing. So for all the others.
A very good morning. So my study compared the transepithelial PRK versus alcohol-assisted PRK. It's a contralateral eye comparison in 40 eyes. So it's a single-step procedure. The comparison was regarding the pain, the epithelial healing, the visual acuity, the corneal haze with a 1-year follow-up. The study design is a double-blinded, randomized contralateral eye study. It was done from 24 April to March 2025, and 20 subjects with 12-month follow-up ranged in the age group of 18 to 45 years, and the spherical equivalent from minus 1.5 to 10 diopter. One eye was randomly allotted trans PRK, and the other eye alcohol ablated was done. And we employed the Schwind-Amaris 500 Hertz with smart pulse technology. And post-operative assessment was performed on day 1, 3 at week 1, and 1, 3, 6, and 12 months. So these were the exclusions, and the preoperative assessment included uncorrected and best corrected visual acuity, the refraction, the intraocular pressure, the slit lamp examination, the fundus examination, the tomography, the corneal epithelial mapping as well. So alcohol ablated method, we applied 20% ethanol via the 9 mm well for 30 seconds, and after which excimer ablation using the Schwind-Amaris was done, and then following which mitomycin C was applied for 10 seconds per diopter, and copious irrigation with chill BSS was done. So in trans PRK, it is an all laser single step touch free procedure. The epithelial ablation 55 in the center and 65 at the periphery, and also based on the epithelial mapping, a little modification was done for certain thin epithelium, and no suction, no flap, no cap technique, with mitomycin C being applied at 10 seconds for every diopter for a maximum of 2 minutes, and cold BCL was applied later. And it's a single step. It is not a two-step procedure. It's all laser and single-step procedure, and hence it lowers the risk of the dehydration as well as this decentration errors as well. So this Fuller-in technology also ensures a smooth corneal surface and healthier and smaller, healthier, nearer epithelial edge and faster reepithelialization as well. So these are the post-operative regime. Prednisolone acetate from day 1 for a week, then loteprednol for 3 months, and then moxifloxacin till the BCL was removed. So these are the post-operative assessment. The epithelial healing was assessed with fluorescent staining, and the pain assessment with McGill questionnaire on day 1 and day 3, and the visual acuity with Snellen's, and then the refraction was done, and the corneal haze with Fantas scale. So these are the statistical analysis, and the baseline ophthalmological assessment between the two study groups. It doesn't show much variation, and it's not statistically significant, and the uncorrected visual acuity gradually improved from week 1 to the third month, and there wasn't any statistical significance between the alcohol ablated and the trans PRK group. And the manifest refraction, left behind a residual refraction of 0.25 in either cases. And we have the efficacy at 12 months. It showed a significant visual improvement in both the groups. The corneal haze was also comparable. And then regarding the epithelial and the pain score, we found that the epithelial healing was definitely better, and with trans PRK, in an average it took just 3 days, and an alcohol ablated it took around 5 days. And the pain score on day 1, it is this is a illustration of the epithelial healing pattern, and then the epithelial healing is definitely better with the trans PRK group. By day 3, almost 9-10% healed, and in alcohol ablated, only 62% showed significant healing. And first and third post-operative day, the pain was more on the alcohol ablated group, whereas on day 3, the pain was almost settled, and it is comparable. So this is a comparative study, and this is a postcorneal haze. It's just 2, and it was only 0.5 in alcohol ablated group, and it gradually improved and completely resolved in a month's time. So this is the resolution pattern, and the strength of this study is it's a single surgeon study. It minimized inter-individual variability, and the limitation is it's a small single center cohort of only 20 persons, and it relied on subjective pain scales. And clearly the trans PRK has an advantage that it has a 40% faster healing and less pain on day 1, and no alcohol toxicity risk as well. So to conclude, this trans-PRK provides faster healing and reduced pain compared to alcohol ablated, but equivalent efficacy in both the groups, and it is definitely safer at 12 months. Thank you.
So, Kavita ma'am, I have two questions. One is ethical committee clearance was taken for the study.
Yes, it was done.
And I mean, why was this study done? Because since years we know that trans PRK is better than alcohol assisted.
Yes.
So, I mean, what was the purpose of subjecting the patients to one eye alcohol assisted and one eye trans PRK?
A few studies did say that the epithelial healing is actually comparable between the two groups. So this study just to express that this trans PRK is definitely better and the healing is certainly faster.
Ma'am, trans PRK now is around 10-12 years old technique, and it has been well established that because it's an all laser technique, the healing and everything, the pain tolerance, the epithelial healing is much faster compared to any other technique for that matter. So, when was this study done?
This was in April 2024 to 25.
Okay.
Did you do epithelial mapping in all the patients before
Yeah,
the
it
surgery?
was done.
It was done in all the
Yes.
patients. So you're all right. Sure. That's all. Thank you.
Thank you very much.
So I think Dr. Disha is here, right? Okay, yeah, sorry. So I think Dr. Arnav wanted to go before because he has one IC. So we are going to listen to Dr. Arnav Saroya. He's going to speak to us about Smile Extra minimally invasive approach integrating lenticle extraction and cross-linking in refractive surgery. This is the free paper number 2225 and the membership number of S24420.
A very warm good morning, everyone. I'll start my topic, Smile Extra procedure and advanced approach integrating the lenticule extraction and corneal cross-linking for refractive correction. So refractive surgery in myopic patients with high refractive error, thinner corneas and borderline topography is a very challenging decision, with the most feared complication being regression and postoperative ectasia. Cross-linking, which works as an effective modality and age-old modality, it helps to strengthen the cornea in borderline cases, keratoconus and even ectasia after the refractive surgery. What we did, Relax Smile, when combined with cross-linking intraoperatively, can further prevent the risk of future ectasia in susceptible individuals. Hence, this study was undertaken to observe the safety and visual outcomes. The study was approved by the Institutional Ethics Committee and adhered to the tenets of the Declaration of Helsinki. The inclusion criteria was age more than 18 years, altered topography in susceptible cases, stability more than 1 year, a BCV of 6.9 or better, refractive error up to -10 diopter spheres and -5 diopter cylinder, and CCT more than 450 microns. The exclusion criteria being unstable refraction, significant ocular diseases, previous corneal surgeries, autoimmune diseases, established keratoconus or hyperopic refractive error, and history of other infections. All patients underwent a preoperative clinical examination, including the slit lamp biomicroscopy, manifest and cycloplegic refraction, dilated fundus examination, uncorrected and best corrected distant visual acuity, topography, aberrometry, contrast sensitivity, and dry eye assessment. The procedure, the Visumax femtosecond laser was used to create a refractive lenticule with an optic zone ranging from 6 to 6.5 with a cap diameter of 7 to 7.5 and thickness 120 microns. Lenticule was then dissected and extracted through a 2 or 3 mm superior incision. After removal of the lenticule, 2 ml of 0.1% riboflavin solution was injected into the interface and allowed to diffuse for 60 seconds by washing the interface with saline. This was followed by accelerated cross-linking, which was performed at 365 wavelength at 30 milliwatt per centimeter square for 1 minute 54 seconds through the cap. The total energy was 3.4 joule per centimeter square. So that's what we demonstrated: lenticule extraction followed by injection of the dye, followed by surface washing. These were the exact parameters which were fed, and a note was made in the post-operative details as well. The follow-up was done at day 1 week, 1 month, 3 months, 6 months and 12 months post-operatively, and recording of the uncorrected slit lamp examination topography was done. Clinically or topographically, none of the treated eyes showed signs of regression or post-op ectasia. As we can see, the slit lamp examination showed very minimal interface haze on the first post-operative day, which further reduced on the consecutive follow-ups. This is the slit beam. This is the ASOC depicting the smile extra interface and the demarcation line as well. Post-operatively, the patient was started on lubricants around 6 to 12 times for 4 to 6 weeks or more if required, along with topical moxidecsa combination and 0.1% prednisolone on an hourly basis for first 4 days only. And along with that, cyclomune 3 times for 4 weeks. The results, 38 eyes of 19 patients with mean age of 25.21 were treated, and mean follow-up was 6 to 12 months from the date of surgery. Long-term studies have shown promising results with excellent visual outcomes, as it has been done in other cases like PRK extra as well. But those patients have had significant haze. All patients were comfortable with no intraoperative or postoperative complications. The demographic and the preoperative data is summarized in this table. Adjuvant techniques that use collagen cross-linking during laser refractive surgery have been proposed as a solution to maintain the structural integrity of the cornea and prevent ectasia. With promising results, PRK and LASIK combined with rapid cross-linking have been used in expanding the pool of candidates that can be treated with different surgical modalities. Based on few studies done before, we took things a step further and devised this. This is not our first study, but it is second or the third study, Smile Extra, which entails concurrent high influence cross-linking of the cornea after Relax Smile. Thank you.
So your cutoff was 450.
More than 450 microns, yes.
So we normally take 470 or more.
Yes. So because we had borderline cases and we were anyway going to do the cross-linking
So
process.
if you had borderline cases, why didn't you take them for phakic lenses instead of doing the Smile Extra?
As it is an intraoperative procedure, mostly patients were a little more comfortable going with the explained risks of Smile Extra, and also because we had already done the studies and showed the results to these patients that initially maybe you will have some post-operative haze.
Yeah,
but
haze is
still
an important
yes,
problem
but
because
yes,
it interferes, because if you compare the quality of vision which
Yes.
they would have got with a phakic lens compared to Smile Extra, definitely the quality will be more. And what did you do any, like, I am sure
The-
you must have not
yes,
done
ma'am.
any biomarkers or anything of that sort to know that the patient will have haze or not?
Yes, and the only the option of an ICL of an intraocular lens was given to the patient. The only thing, these patients were chosen only when they didn't want to go for any intraocular surgery.
Okay, what is
The
the
pool of
range of
patients
power
could
you
have been much
corrected?
more. Sorry.
What is the range of power you corrected?
The highest power, ma'am, that even I had done was around minus 10, minus 11.5 square and minus 2 cylinder.
Do you
That was
think
minus.
that minus 11?
Patient had a very good corneal thickness. He had more than 645.
So then, if he had very good corneal thickness and everything, then why you want to do Smile Extra?
The patients were told that if uh, uh, in the initial post-operative phase, the patients were also outstation patients. They told we cannot come for regular follow-ups. So only those particular patients were also suggested that you can go for Smile Extra. Otherwise, not every patient who was borderline corneal thickness, they were subjected to the cross-linking
No,
procedure.
what I'm not able to get is, one side we are saying borderline, other side we are saying you corrected minus 11 with some cylinder.
Yes.
That's impossible to correct with
With a high
borderline.
with a high corneal thickness, ma'am. Not all patients had a the cutoff was it should not be the RBT should not be less than 280 in any possible case.
I actually am little skeptical because 450 is a less cutoff. 300 we usually keep.
450 is the yes, but
Right,
280 is what we used to
Okay,
follow in our institution.
Okay.
What was the maximum follow for your patients?
Sir, up to 8 to 9 months. This was during my fellowship, which was completed last year in September. But 9 months we had a thorough follow-up. In the first post-operative day only we used to have the haze. Otherwise, in the 1 week and 1 month follow-ups, the patients were absolutely comfortable.
Yeah. So why the follow-up is required is not for the haze actually, because we
Yes.
are looking at susceptible corneas.
Corneas.
It is
And-
required to see the ectasia.
Yes.
So all these patients, of course, have to be followed very judiciously.
The topography.
If the
and-
patients can't come back for follow-up, they should be referred to some center where
Yes.
they can follow it up.
The topography
Alright,
was
yeah.
done at every follow-up.
Sure.
So which institute was this? Where did
Dr.
you?
Agarwal's Chennai.
Okay.
All right, thank you. So I think we'll go to the last presentation by Dr. Disha Goel. She is here. Yeah. So Dr. Disha is going to talk to us about outcomes of cyclotorsion compensated calyx for correcting myopic astigmatism.
Good morning, everyone. I'm Dr. Disha Goel. I'll be speaking on the outcomes of manual cyclotorsion compensated calyx for the correction of myopic astigmatism. So SMILE was FDA approved in 2016 and which was extended in 2018 to include the treatment of myopic astigmatism up to 3 diopters. With the emergence of various refractive lenticular extraction procedures, a consensus has been made to use the term calyx for these procedures. Calyx definitely presents an advancement over the flap-based procedures with comparable safety, efficacy, and predictability and better biomechanical strength. There is a tendency towards undercorrection after SMILE in treating astigmatism, mainly because of the lack of inbuilt cyclotorsion control in the Visumex 500 machine, and also a lack of inbuilt centration and various other factors. Review of literature. So, various studies in which there is no cyclotorsion compensation, the results of SMILE in myopic astigmatism tend to show undercorrection of astigmatism. Meta-analysis published in 2023 also showed that there is less astigmatism refraction predictability with more undercorrection in SMILE. There are a few studies which also talk about cyclotortion compensated SMILE and myopic astigmatism with varying results, like Paichan et al. Concluding that it leads to significant improvement, whereas Gitansha et al. Stating that there is no additional advantage. Now, rationale of the study is since there is a lack of cyclotorsion control on the Visumex 500, there are concerns regarding the capability of SMILE to correct myopic astigmatism. This lack of cyclotorsion compensation control can be compensated with preoperative manual 0-90 180 degree limbal axis marking and its intraoperative matching with the reticle on the platform. So our objectives were first to study the visual and refractive outcomes of the procedure, second to evaluate the efficacy, stability and predictability of the same. It was a prospective study done at RP Center Ames for 18 months. 93 eyes of 57 patients were taken. The study was started after the ethical clearance and consent was taken from all the patients. Patients with myopic astigmatism ranging from -0.5 to -3 diopter were taken in the study. Preoperatively, a 0-90 180 degree limbal marking was done on slit lamp using a gravity assisted bubble marker. Intraoperatively, 0-180 degree mark was extended onto the optic zone, followed by matching of the limbal marking with the reticle on the screen on the Visumex platform by rotating the suction plate before the laser treatment. So this is a video showing the marking in which a plumb line was used to first ascertain the 90 degree mark, and then a gravity assisted bubble marker was used to mark the 0, 90 and 180. Then intraoperatively 0-180 degree mark was extended onto the optical zone. This marking was then matched with the reticle on the Visumex platform, and the suction plate was rotated to align the marks with the reticule. This is a video showing the rotation of the suction plate after docking and before the initiation of the laser treatment. Analysis was done. Results. So we saw that 26% of the patients did not require intraoperative rotation. Uncorrected visual acuity improved significantly as expected, and 90% of the patient had 6/6 at post-op 6 months, with the remaining patients having 6/6 parts. Best corrected visual acuity was both 6/6 preoperatively and postoperatively. Refractive outcomes. So preoperative mean spherical refractive error was -3.64, and there was no residual spherical refractive error. Preoperative mean cylindrical refractive error is 0.84, with 90% patients having zero residual cylindrical refractive error, 6 patients with residual -0.25 diopter, and 3 with +0.25 diopters. Aberration, there was no significant difference in total aberration, but there was a significant increase in higher order aberration. Efficacy was found to be 0.98 at at post-op 6 months, and the safety index was 1, with 100% eyes within plus minus 0.25 diopter of the targeted refractive astigmatism. A vector analysis was done based on Alpine's method, and various parameters were calculated, with percentage success of the astigmatism surgery found to be 94% at post-op 6 months. So, since Vizumax 500 lacks cyclotorsion control and depends on surgeon-dependent centration that is concerned regarding the treatment of myopic astigmatism, we employed a 0-90-180 degree limbal axis marking with its matching with the astigmatic meridian of the reticule on the Vizumax laser platform screen by rotating the suction plate. In our study, the mean cylindrical refractive error was minus 0.84, which is lower than the previous studies, but since it was our initial venture into employing manual cyclotorsion compensated calyx, we chose a prudent approach. In our paper, we found the predictability to be 100% within plus minus 0.25 diopter astigmatism, which was better than the previous studies, which can be attributed to our cautious approach again. The varying conclusions of the influence of manual cyclotorsion compensation in calyx surgery in the previous studies can be attributed to variations in marking errors, technique differences, absence of control group, overcorrection nomograms. Though the total aberrations were unchanged, higher order aberrations increased, which can be explained by the removal of the lower order aberration by the correction of spherical error and offset by the surgery-induced higher order astigmatism. Limitation: there was a small sample size, and also there was a lack of comparison group, which was chosen because of ethical reasons. Technological advancement. Now, since Vizumax 800 with Smile Pro has been FDA approved in 2024, which has a feature of central line and oculine cyclotorsion adjustment, recent studies by Reinstein et al. With 118 eyes with a 3 months follow-up with preoperative cylinder of minus 0.98, which is similar to ours, showed 51.8 eyes within plus minus 0.25 diopter versus our 100%. Study by Saad et al. With 152 eyes in 3 months follow-up, preoperative spherical equivalent was minus 4.4 with 91% eyes within plus minus 0.5 diopters. Conclusion: so this approach of manual cyclotorsion compensation is a straightforward method for enhancing the outcome of astigmatism correction with calyx with Vizumax 500 platform. We have also observed that gently rotating the cone post-docking does not result in suction loss. So it is a simple reproducible technique, and a refined marking method has been given by the study. Recommendations: so it is a safe, feasible, effective approach to refine the results of Smile in low to moderate astigmatism. Studies should be done to understand the effectiveness in moderate to high astigmatism, and also studies to compare the manual cyclotorsion compensated Smile with inbuilt oculine cyclotorsion with Vizumax 800 needs to be done. Thank you.
Thank you. So, did you use any personalized nomograms, or they were whatever was the refraction was the one which was fed?
Yes.
Okay. So, the previous studies which were done by both, I think, Dr. Sri Ganesh and Dr. Gitansha, they did they use the nomograms, or
10% of overcorrection nomograms were used in those studies, yes.
so in your case nomograms were not used, and you have seen this to be probably a more accurate method of doing the procedure compared to them, apart from, of course, the cyclotorsion compensation. So basically, this in this case, you have gone up to 3 diopters of astigmatism.
We did. Our inclusion criteria included up to 3 diopters, but our range, what the patients were included, the range was from minus 0.5 to minus 1.75.
Okay, so
Yes.
they were okay.
A little on the moderate side. Yeah.
All right. All right. Any other questions, Dr. Monia? Yeah, sure. Okay. Thank you so much.
Thank
Thanks, ma'am. Thanks. So, any other presenter is here? Dr. Himanshu. Okay. Right. Dr. Himanshu Khandelwal? All right, sure. So, I think you're going to speak to us about impact of oral administration of lactoferrin post-refractive surgery, dry eye. So,
Nice talk. Yeah.
why you got delayed, Dr. Himanshu?
The traffic and the distance, I don't know. Good morning, everyone. My topic of discussion is impact of oral lactoferrin post-refractive surgery, dry eye. As you all know, dry eye is a multifactorial disease of the ocular surface, which is characterized by a loss of homeostasis of tear film and accompanied by ocular symptoms, in which tear film instability and hyperosmolarity, ocular surface inflammation, and damage and neurosensory abnormalities play etiological roles. And the prevalence of post-refractive surgery dry eye at 6 months is around 36 to 75%, which can be caused by the surgical transection and laser ablation of corneal sensory nerve fibers, resulting in decreased corneal sensitivity and interruption of the corneal neural lacrimal reflex arc that controls tear production and blink rate. So lactoferrin is an iron-binding glycoprotein present in the tears, has been identified for its role in maintaining ocular surface homeostasis. It exhibits anti-inflammatory, antimicrobial, and antioxidant properties, all of which could help in mitigating inflammation and promoting healing. The proof of the hypothesis of our study comes from these studies, and to come and aims and objective of our study is to study the impact of oral administration of lactoferrin in refractive surgery induced dry eye, evaluate ocular surface health in post-refractive patient, and assessment of corneal nerves in post-refractive patients. So it is a randomized placebo-controlled trial. We have enrolled 128 patients, around 256 size, which is done at Dr. R.P. Center for Ophthalmic Sciences, AIMS, New Delhi, from March 24 to December 25. The parameters which we have assessed the ocular surface disease index, non-invasive tear breakup test, Surmus test, and LipiView and ocular surface analyzer. So these are the packets which are available through our project. It's a lactoferrin tablet and placebo tablet. Both are similar. Just we have a difference of a dot in a code to identify the lactoferrin tablet. It is given 250 milligram BD before meals to maximize the absorption, and the placebo tablet have contain maltodextrin, which is a starch molecule, which is a inert molecule, FDA approved. So coming to our result, total 256 size post-refractive surgery were included in our study, and mean age of the patients was found to be similar in both the groups. So at 3 months, the lactoferrin groups shows significant improvement in OSDI, NIVUT, and Shermer's test, and in LipiView also shows improvement, but not that significant. And to assess the corneal nerves, we use the in vivo corneal confocal microscopy, which are done at HRT Heidelberg tomograph, and we examine the central cornea to capture the corneal nerves, and we can see the pre and post PRK. Usually, the corneal in post PRK, the epithelium shows hyperreflectivity, and there is a significant damage to corneal nerves in the post PRK and the post LASIK in both the groups. So the nerve assessment is done by using a ACC matrix method, in which the corneal nerve fiber density and corneal nerve branch density both are used. And we can see the results as we can see the significant improvement in Shermer's, NIVUT, and OSDI scores. And to conclude, the use of oral lactoferrin tablet is a safe addition to post-refractive surgery patient. It also reduces the post-refractive surgery dry eye symptoms and can be reliable nutritional supplement for the dry eyes. Thank you.
So, Dr. Himanshu, do you know where, other than ophthalmology, where is lactoferrin used?
Ma'am, till now it's done on the animal models, and the one in US.
No, you didn't. Did you get my question? I'm asking, other than ophthalmology, in which specialty is lactoferrin used?
Sorry, ma'am.
It's okay. In gynecology, it's used. It was always used in gynecology since years. It has got a renewed interest in ophthalmology recently. It's a very old molecule. Now it has been used in ophthalmology.
Yes,
So is this the first study, or there
yes,
are?
ma'am. This is the first time.
So there is no other study in the literature about this?
No, ma'am.
No, I know. Okay. All right. Thank you.
Okay, thank you.
Thanks.
And if I'm not wrong, only one company is making this, right?
Right now, oral lactoferrin is not made by. Came in under project.
No. It is being made by a company. We are using it. Ectoferrin.
It's drop, ma'am.
No, sir. It is available in tablet form. I'm using it. So if you're presenting, you should know whether it is available or not. Okay. It's okay.
Sure. Thank you. So I think as we come to the end of this session, thank you to all the presenters. Very exciting sessions and very, I think, well-made presentations. Congratulations to each and every one. Of course, it is unfortunate that some of the presenters were not present. I think this is something that we have to look at in the future, that this should never be done actually in this such a prestigious platform. I would like to also thank our judge, Dr. Monica, for being here. And so we look forward to the rest of the AIOC. All the best. Thank you so much. Thanks. Thank you. Thank you.
Group photo.
Okay. We'll have a group photo of all the presenters who are here. Please.
To 5%. So what is refractive amblyopia? There are 3 types of refractive amblyopia: isometropic, anisometropic, and meridional. The most common type is the anisometropics, and the refractive correction with the spectacles, contact lens, and the occlusion therapy are the traditional treatment for the refractive amblyopia. However, this mode of treatment are associated with poor compliance in adults. So why phakic oil for the amblyopia? Therefore, there is a strong need for alternative treatment strategies to manage the adolescent adult patient with a high myopic amblyopia. The laser vision correction emerged an alternative corneal refractive surgery technique that are effective as well as safe for young adults. But refractive amblyopic patient who cannot undergo the laser vision correction, phakic intraocular lens implantation is an effective surgical correction technique in managing the amblyopia. Why customization of the phakic eyeball? Then Anthropoli and Zhang et al. Showing in their study there is significant improvement of the quality of the vision and the quantity of the vision when they implanting the phakic eyeball in the suspected amblyopic eyes. And these two studies paves out this clinical research. Aim of the study to analyze the demographic and clinical outcome for the posterior chamber phakic owl implantation for the refractive amblyopia in a young adult, to note the refractive outcome, improvement of the VCV and quality of the vision with respect to the changes aberrometry, to measure the efficacy and the safety of the posterior chamber phakic owl. Methodology is a single center prospective interventional study and conducted in tertiary eye care center in India, and the Kolkata duration study 2021 to April 2024, where the 14 eyes of 20 patients were included in the study. Patient demographic, pre and post-operative visual acuity, cyclopedia fraction, anterior and posterior segment examination in IOP, pachymetry, contrast sensitivity, endothelial cell count, and the patient satisfaction square were evaluated pre-operatively as well as the 6-month post-operatively. And all the patient, the pre-operative and the static analysis done between the pre-operative value and the 6-month post-operative value, in where the inclusion criteria was age more than 18 years, stable refraction, tomographic is stable, and acuity is 2.8. And all the patient before undergoing the surgical intervention, we have done the RGP and meniscal tunnel when there is showing there is a one line improvement. That's mean patient having the visual potential is there, and we have done the surgical taken the patient. Exclusion criteria: refractive error less than -6, nystagma, sensory blindness, autoimmune disorder, corneal ectasia, and any other ocular comorbidities. And the Wilcoxon sign rank test were done for the static analysis, and the static analysis done between the pre-operative value and the 6-month post-operative value. But the mean age of the patient was 21 years out of 15. Out of 14 patients, the first 7 were the female, and the 5 were the 7 were male, and the 5 were the female. And the BCV were in the post-operative, the UCV showing significant statistical improvement when you compare the pre-operative use the BCVA value. And even though the logmar value when showing that when we compare the post-operative UCVA value with the RGB pre-operative value, that's also showing statistically significant. And the real time we observed that at least minimum 2.6 to 3 line improvement each of the patients. And aberrometry value, that also showing the significant reduction of aberrometry. That indicates that not only the quantity, the quality of the vision is also improved. And this is a real time picture of the aberrometry value. And none of the patient, this is the mean the spherical equivalent of the patient, which was statistically significant post-operative values. None of the patients showing any endothelial decompensation or intraocular pressure in suit of after the post-operative procedure. And the patient satisfaction, all the patients are highly satisfied after the phakic IOL implantation. So this is a mustard chart, and this is the line diagram showing initially there is improvement is there. That improvement indicate the patient having the itself the effect of the phakic IOL. But what we observe from the 1 month to 6 month onward, there is a further improvement 1 or 2 line. That indicate that improvement probably due to the neurodevelopment and improvement. And that indicates definitely the phakic IOL has some role in the treatment of the amblyopia. So our study, we have done the 14 anisometric eye, all the showing significant improvement, and the already published data in IGO and KJO that is supported our study. None of our patients showing the endosubcapsular cataract or secondary glaucoma. So these are the relevant studies. So in conclusion, posterior chamber phakic IOL is a safe, effective, and the alternative methods for treating the amblyopic patient who are non-compliant to the glasses, contact lens, and the keratorefractive procedure. It is clinically observed and statistically proven in this study. Perhaps this is the first documented study in the adult age group in India. Thank you very much. Thanks for your patience sharing.
Thank
These
you,
are
Dr.
some of the
Shah.
patients' testimonial who, without disclosing their identity, who underwent the phakic IOL implantation for the adult amblyopic therapy.
All right, sure. Thank you. So you have compared the uncorrected visual acuity post-op with the best RGP corrected contact lens corrected acuity pre-op.
Yeah,
Yeah,
we have compared the first patients use BCVA, whatever the best corrected, and the post-operative UCVA, and it is definitely unaided vision also. Whatever the patient had the vision pre-operative BCVA, it is whatever we observe these things. Definitely, it is more than that. Most of the 90% of the patient, as well as when we compare the post-operative value of the UCVA, compared to the RGP preoperative tube also, that was showing there is a significant improvement is there. And what we convey these things that all of us know that when we implant the phakic there is a immediately improvement of the vision is there, and that improvement itself for the effect of the phakic because that is a retinal image magnification, and we place the IOL in the close to the nodal point, so that is all proven. But what if that is that, that's why there is a whatever the patient have the BCVA, whatever the preoperatively, and we observed is the patient without UCVA same thing or more than that. But what we observed, what I shown this line diagram, all the 49, what during almost all the patient follow more than 3-4 years, down the lane after 3-4 months, that is another line of improvement is there, and that improvement probably the neurodevelopmental improvement. So that is indicate that it has some role definitely, and whatever the we are implement on convey the message in the study that definitely it has some. Those the patient are poor compliance because most of the patient some of the patient anisometropy -6 -7, and the other they are suspected amblyopia, and probably the by BCVA or the RGP improvement 1 or 2 line. When you place the phakic definitely they have improvement more than 1 or 2 line whatever the BCVA they had. But further there is a 1 or 2 line one at least minimum average of 1 or 2 line improvement during the follow from the 3 month to 6 month or beyond that. Even also whatever same this actually this concept has clicked on mind. Even also when we do the LASIK reservation correction too also, what I suspect the patient having the we do the reservation correction, there is improvement is there. Further if down the patient having the swing, there is another improvement. And probably these things that probably the second improvement is due to the neurodevelopmental improvement. That indicate probably that it has some role in the and phakic in the adult amblyopic therapy. Already this we have compared when we compared the study with that are already published in AIOC by that are these things, and already that is showing in adolescent age group. And but in our study we have done in the adult age group, but the mean age is 22 years. So whenever we suspect sometimes that the adult there's no any improvement is there, yeah, there is an improvement is there.
Sure. Okay, I think because of lack of time, I think we'll wrap it up now. Thank you so much.
Thank
And
you
we'll
very
give
much.
it to the next session. Thank you so much.
Thank you very much.